Well, good afternoon, everyone. I just want to thank the organizers for having me speak here today. What I've been tasked with is talking to you about the role of lymph node dissection in high-risk disease, and also to tackle, as was asked earlier, this whole concept of salvage dissection. So when I was thinking about this talk, I think there are sort of four key questions that came up. The first is, can we actually cure patients with lymph node disease? The second is, what would be the role of lymph node dissection in terms of how far to go, both in patients with localized disease and also in patients who have clinically node-positive disease, if a surgical approach is appropriate for that patient. We'll talk also about the role, as I alluded to, of salvage lymphadenectomy in patients with recurrent disease, either those who have failed radical prostatectomy or radiotherapy. And very much it dovetails extremely well with the last talk because the enabling technology of PET has made this, I think, a particularly more relevant topic. And then lastly, I think perhaps one of the things we all need to think about for the future is if we don't cure patients with salvage lymph node dissections or with aggressive lymph node dissections, but we keep them free of disease longer, in other words, delaying particularly hormone therapy, are we doing them good? And that's, I think, a very interesting question. So to answer the first question, is node-positive disease curable? This trial was just mentioned earlier by James Eastham, the famous Messing trial where patients were randomized if they had node-positive disease at radical prostatectomy to surgery, lifelong hormone therapy or no therapy. So we could look at the control patients from that trial. I actually pulled this out of the 2006 Lancet Oncology paper in green. You can see that 86% of the patients in the observation group had at least PSA recurrence. Obviously, the complement of that, 14%, in theory, were cured. They were PSA-free, and this was a median follow-up, you can see, of 12.3 years. So I think we'd all be fairly confident that there is a subset of patients, and in this case, it was with largely an obturator and external iliac dissection that can be cured. So what about defining the anatomy and the templates? I want to take your attention to this side view of the pelvis. The yellow is the obturator nerve, and this area called number 2 is what we typically call a limited pelvic node dissection. It's the obturator lymph nodes, but there are also lymphatic tissue deep to that in the deep pelvis, and then one could go wider out to the external iliac, going up to the aortic bifurcation. Now, other templates have also been described, so we have the 1, 2, and 3 that I mentioned, but there's also 4, which includes the presacral nodes, and then you can start marching up higher and higher into the retroperitoneal space. I think for just the purpose of having a standard nomenclature, a limited node dissection would be the classic obturator nodes. The standard would probably include the obturator and external iliac. Extended would also include the internal iliac nodes, and the super extended would include the presacral, and you can even go up into the retroperitoneum. Now, it's interesting if you look at mapping studies that have looked at the question about order of lymphatic spread, as has been done in testicular cancer. It's not as well understood in the context of prostate cancer. Generally speaking, the primary classic landing zone is the obturator nodes, but some patients will have this level 3 or even the presacrals as their first step in terms of their metastatic progression. Interestingly, higher lymph nodes don't seem to occur unless you have this level 1 or the external iliacs involved. That seems to be the route higher up to the retroperitoneum. So using this approach, I think we could come up with some perhaps recommendations in terms of what to do from an anatomic point of view. I will also say, which has been mentioned earlier, I think by Dr. Carroll, the PSMA PET era has called a lot of this into question. We are seeing very strange, heretofore strange, metastatic patterns, particularly the mesorectal nodes, which we never thought were particularly involved in prostate cancer, but we're starting to see a lot of mesorectal node involvement, particularly in patients with high-risk disease. So, what about the impact of more aggressive lymph node removal? What do we know? Well, for sure, the bigger node dissection you do, you're going to get more nodes removed. That goes without saying. However, there are other factors that have been shown to also predict the nodal yield. It's separate of the extent of the template. The pathological thoroughness, how hard the pathology and the pathologists and their technicians look for lymph nodes. The surgical approach, there's some evidence, perhaps the open is better than the robotic, and I know some of the robotic surgeons get a little miffed about this, and I think with more refined techniques, they seem to be fairly equivalent. Meticulousness, without doubt. Packet submission, if you submit your packets in multiple pieces versus en bloc, you're gonna get more lymph nodes. That's been also revealed. It's also been shown that obesity also affects the nodal yield. So the first thing we know, if we do more extensive node dissections, we get more nodes. We also, not surprisingly, get more positive nodes. And in general, you can see that the more nodes that are removed in this one particular paper using a more extended template, they had 13.5% versus 3.4%. So clearly, if we take out more, we're going to find more cancer. The other thing we know is that the morbidity is just marginally higher. Although you're more prone to lymphocele and lymphedema, interestingly, the DVT rate seems to be defined by the dissection around the external iliac vein. So given that the obturator pluck is sort of the standard, there doesn't appear to be much higher a DVT rate by going more extensively, particularly in the pelvic area. Now, what about the oncologic outcomes? And the data are quite poor on this question. And most of the studies here are single series, non-randomized, and there was a reference made earlier to the MSK protocol, which we're looking forward to hear about in the coming years. Generally speaking, some of the data suggests that the BCR rate is better. That doesn't mean the cure rate is better, because the curves may just converge 6 months later, 12 months later, 2 years later. In this particular paper, although there was a better BCR rate when they matched it in more propensity technique, the beneficial effects were eliminated. In this particular paper, there was benefits only in subsets of patients. This is an interesting paper. It was published just last year, where they took a large institute, but they had multiple surgeons doing the same extended pelvic lymph node dissection. And here they showed that larger nodal yield was associated with better CSS. This is not a different template. This is just more nodes removed by different surgeons within the same group doing ostensibly the same operation. Now, we've heard about this before in bladder cancer. Whether these are surgeon-related differences, maybe this has nothing to do with removing the nodes. Maybe this is a reflection at the prostatic apex or at the lateral border. We don't really know. We don't know if this is the determinant of the outcome or there's another latent variable that's just somehow linked with procuring more lymph nodes. Now, there may be other reasons why patients who have more lymph nodes removed do well. And I always like to think of some of the biologic basis for this more than just the mechanical aspect of being a surgeon. This is an interesting paper that just came out that showed that positive pelvic lymph nodes in patients actually are overpopulated with immune suppressive CT4 cells. So there may be a biologic basis whereby the immunity, if you will, and the cancer-specific immunity is somehow affected, and therefore by removing more lymph nodes, it may be in a weird way, a way of stimulating the immune system, almost perhaps mimicking an immuno-oncology type of setting. I think there's also quite interesting biology around exosomes, and for those of you not familiar with exosomes, these are little packets, little membrane packets that are secreted by cancer cells. It's estimated that every cancer cell secretes hundreds of these every hour. And they're little bits of nucleic acid and protein material, and it serves as a bit of a, like a drone, if you will, from the primary tumor, and they float around, and it's unclear what the biologic effects of these exosomes are, but it's starting to become elucidated and perhaps forming a bit of an endocrine system by which the primary tumor and its metastatic sites talk to one another. This is, I think, a very interesting paper where they actually took 2 separate tumors as xenografts in a mouse. And one of the tumors had an integrin signal. It was an aggressive type of tumor, and the other was a more indolent tumor, but they both had metastatic potential. And over time, the metastatic sites, tumors that originated from the second more indolent tumor picked up the integrin signal from the more aggressive tumor, a form of intergenic transfer, if genetic material transfer. And the corollary, or the idea behind this, is that if this can happen among disparate tumors, then certainly different clones of cells within the same patient may have a way of communicating with them. So perhaps removing a positive lymph node does have an effect in delaying other tumors from becoming more aggressive in the future. And this is just a similar study in this case showing that exosomes confer chemotherapy resistance. In this case, it's an in vitro system. And again, I think this paper was referred to earlier, but it's a very interesting paper published in Nature 3 years ago where they looked at the sort of trunk and branch origin of prostate cancer and its metastases. And again, there's clear evidence now that we do have lymphatic to lymphatic and lymphatic to bone spread. It's not always from the primary site. So there may be a biologic basis on top of just removing the cancer cell, if you will, in terms of doing more extensive lymph node removal. What about in patients with just clinically node-positive disease? The role of surgery in these patients, obviously a lot more controversial. The data are quite poor, single series. But one thing that is important to recognize is patients with node-positive disease, but even bulky disease, live a long time. The average survival is about 9 to 11 years in those patients. And in light of the benefits and improvements in systemic therapy, this is likely to be even better. This makes perhaps a better case for a local therapy and perhaps makes a better case for more extensive removal of the lymph nodes to also control the pelvis. This is one paper published from the Mayo Clinic group looking at patients with clinical lymph node positive disease, and you can see here that this 10-year CSS is 86%, so these patients do well, although many of them did receive hormone therapy. Let's move to the very interesting topic of salvage lymphadenectomy. So the first very important point, as was mentioned earlier, is we all know that bone scans and CT scans are poor in terms of staging patients. And this is a really interesting paper where they looked at the clinical impact of PSMA PET in patients who have recurrent prostate cancer. And I think what's interesting in this particular paper is that in 3/4 of cases, the results of the PET scan was sort of a very important determinant of next step. And I think if you're going to embark on this approach today in 2017, you must have a PET scan. There's no point, in my view, going after nodes in the pelvis in a patient who has multiple bone metastases, as was just shown, for example, with the last speaker. So this is a critical, I think, enabling technology to enable us to look at this question again. So what about the results? What about going after lymph nodes in patients with recurrent disease, PET scan, positive? In this case, it's either choline or by PSMA. You can see here the results of 5 different trials. And I think what they seem to suggest is that in a subset of patients, this is not a home run, but perhaps in 10 to 20% of patients, a durable biochemical CR is achieved. In about 1/3 of patients, there's no effect whatsoever. And then in the remainder, perhaps 40 to 50%, there's somewhat of a slight delay, probably not of much clinical significance. The data are very single-center based. Many of them use hormone therapy, which obviously blocks the ability to truly examine the impact. This is another paper published just this year, looking at 87 patients with rising PSA. You can see here they had PET, either PSMA or choline, and again, these are the take-home numbers. They did better than most, about 27% in their series, incomplete response at about 40%, and no decline in 31%. And this gets to this question of time to ADT and time to BCR, and I think this is increasingly being used as a justification for doing this, and certainly I tell patients our chance of hitting a home run is probably small, but we may be able to delay hormone therapy. Now, to the degree to which this is clinically significant, I think is something that as a field we need to grapple with and perhaps set forth guidelines in order for us to prospectively evaluate what is really success in this context. This is another paper just recently published by Phil Stricker and his group from Sydney. 35 patients with a robotic salvage node dissection. Interestingly, again, 43% had PSA less than 0.2. Interestingly, important point, there are micrometastatically involved nodes adjacent to the ones that are PSMA PET positive. Just don't go pluck out the positive node. You still need to do a regional dissection. The other interesting aspect of this is there were a few false positives. There are patients who have PSMA positive nodes that were pathologically negative at the time of surgery as well. You wondered, did they miss them? Was the imaging off? Hard to really prove. Generally speaking, though, this is a highly specific test. So the overall impressions about salvage lymphadenectomy, therefore, about 15 to 25% have what I call a home run. And if you think about a third of patients who actually go for a PET scan, if you do it in the 2 to 10 range, have localized disease, you have to do the combinatorial math. When you have a patient who you're thinking about sending for a PET scan, I usually tell them it's about a 1 in 9 chance we're going to hit a home run, meaning there's about a 1 in 3 chance the scan's going to be perfect and about a 1 in 3 chance that the operation is going to be perfect. So you have to multiply those probabilities. As I alluded to, the nodal pluck is insufficient. You need to do a regional nodal removal. As I alluded to, occasional false positives occur. What about atypical sites, non-pelvic disease? Generally speaking, the case reporting on here is poor. The results seem to be not particularly great, and in general, obviously, case reports that are published are the best outcomes. So I would say at this point, certainly treating disease above the aortic bifurcation probably should be done in the context of a trial. I think the results to date, once they're this high, is that they largely don't have a significant PSA drop. And I think in terms of selecting who's likely to do best, clearly patients with discordant metastases, longer duration between primary therapy and failure, and obviously patients with probably lower primary grade do better, and that's always the case in these types of analyses. Let me try and quickly handle this really important point, is that do patients who get non-curative but at least some PSA-free survival benefit from that particular construct, or are they just better off being placed on hormone therapy? And I think it's impossible to really answer this question, but we are increasingly, of course, aware of the long-term complications of ADT, not only the usual ones, the muscle atrophy and the anemia and erectile dysfunction, but a lot of the more subtle ones that are increasingly becoming recognized, metabolic changes, metabolic syndrome, cardiovascular disease, and now some perhaps hint of accelerated dementia. So there are real implications about starting patients on ADT, but I think delaying it 9 months is probably not a win. I think perhaps delaying it 2 to 3 years is. And as I alluded to, I think it's important for us as a field, in order to design a trial, is we need to set forth what is a clinically significant delta in terms of time not on hormone therapy that is worthwhile and something that we can all agree on as a specialty. So I think I'll put this all together and conclude that I don't think we have any doubt there is a subset of patients who have pelvic nodal disease that have curable disease. I suspect it's likely microscopic type disease. And again, it's in that probably 10 to 20% range. Extended pelvic lymph node dissection, I think, is justified, certainly in higher risk cases, because you get better staging, and you're probably going to have a better chance at a BCR. Whether it's cure or not is highly debatable. PET scanning clearly refines this whole question of lymphadenectomy in the salvage and, frankly, even in the primary setting, as was just discussed. And I think without it, you shouldn't embrace or embark on this whole field of trying to do salvage lymphadenectomies. Again, a modest proportion, however, of patients who have this approach seem to do well. I think it's probably a reasonable enough percentage to embrace this, and certainly we have done this at our center, but again, only with pelvic nodes largely and only with a PET scan on hand. And we're sending lots of patients to Germany, and we have some of the same challenges that you guys have. And again, this last point about we need to decide as a field what is the benefit in terms of this construct of ADT delay and what the right numbers are for a parameter to make this perhaps a viable endpoint for clinical trials. Thank you for your time, and thanks for the invite.